Welcome, everyone. My name is Nancy Steinhauer, and I'm the principal at the Mabin School. And we at the Mabin School are so happy to host you here tonight. For those of you who don't know us, we're a little school, just 150 students, JK to 6, boys and girls, in a little house around Avenue in Davenport. And we could never host something this size in our actual building. So one of the things we've learned during COVID is we can gather more people together virtually. And that's been an unforeseen benefit. So thank you for joining us. A big thank you to our panelists who I'll introduce in a moment, and to our moderator, and to Michelle Barchuk and Graham Casson, who have been working behind the scenes to organize this event. The Mabin School is creating the next generation of original thinkers and adaptive leaders and caring citizens. And COVID has certainly forced us to flex our adaptability muscles. But again, one of the great advantages of COVID has been learning that we can share what we're doing with so many more people when we do it virtually. And we're very happy to share this amazing panel with you tonight at such a timely moment as the COVID vaccine for kids has just been approved. This is our third collaboration with SickKids, and we are so grateful to all three of our panelists for agreeing to speak. We have Dr. Ronald Cohen, who's the president and CEO of SickKids. We have Dr. Jeremy Friedman, who's the associate pediatrician in chief. And we have Dr. Michelle Science, who's an infectious disease consultant. And we invited to join us tonight Dr. Maya Goldenberg, who's a philosopher of the science of medicine and has just written a book very recently, well-received book called Vaccine Hesitancy, Public Trust, Expertise, and the War on Science. And Dr. Goldenberg, who's a mom at the Mabin School, has agreed to moderate tonight. So we're very pleased to have her here as well. The format tonight, before I hand it over to Maya, and by the way, we all go by first names at the Mabin School, so we'll be using first names, is that each panelist will speak, and then Maya will lob questions at them that we have gathered ahead of time through your registration forms. And then if we have time, we'll also answer questions that you put in the question and answer part of the Zoom webinar or in the chat. Maya will be monitoring the chat and the Q&A, and we'll answer as many questions as we can by 9 o'clock tonight. So with no further ado, I'd like to hand it over to Dr. Maya Goldenberg. And thank you again to all of our panelists and to all of you for joining us for this exciting event.
Thank you, Nancy, and thanks everyone for being here tonight. We think you've made a good choice coming to get more information about the COVID vaccines for ages 5 to 11. There was a lot of interest in the vaccine and a lot of excitement yesterday. The online provincial portal opened up officially at 8 a.m. And by 10 a.m. it was reported that 68,000 vaccination appointments were already grabbed up, probably by very relieved parents. But we know that not all parents feel that way. There was a survey that was released just last week saying 1/3 of parents in Toronto with children aged 5 to 11 are either unsure or are opposed to vaccinating their children against COVID. Now, the rollout that we've already had for ages 12 and up have given a lot of opportunity to try out different ways of getting information that people need about these vaccines in order to make informed health decisions, and also to learn from the public what are the barriers to getting vaccinated. It seems that public forums like this one have been a great way to address people's questions and concerns, and when it's done well, it is done without judgment. And that's what we're going to do tonight. I'm going to first turn it over to Dr. Ronald Cohen, to Ronnie.
Thank you so much, Maria, and good evening, everyone. Thank you so much for inviting us back and for joining us tonight for what I hope will be like a constructive and helpful discussion. So what we'll do is I will give you a little bit of a general overview about where we are in the pandemic. Jeremy then will talk a little bit more in detail about COVID and children, and Michelle will provide you an in-depth overview about the vaccinations, and then we'll do our best to answer as many questions as possible. So let me start with an overview of the current state of affairs. As all of you know, we are in the midst of a somewhat mitigated fourth wave of the SARS-CoV-2, which is primarily driven by the Delta variant. And that is a variant that yet again has changed the dynamic of the pandemic, as it is significantly more transmissible than previous variants. But there are a couple of important facts that I'd like to emphasize on. Yes, this variant is clearly significantly more transmissible, but it has not shown to escape vaccine immunity. And the current vaccines that we have available continue to show excellent protection from getting severe symptoms and preventing hospitalizations. At the same time, while we continue to see these so-called breakthrough infections in vaccinated individuals, by and large, these individuals experiencing mild disease, sometimes are even asymptomatic, and only in very rare circumstances do these infections lead to severe disease requiring an admission to the hospital. Another important fact to consider is while these breakthrough infections occur, the risk of transmitting the virus when you are vaccinated is still less likely than if you're not vaccinated. It's not impossible, but it is less likely. The other point I think that's important to emphasize is while there is evidence that the Delta variant causes more severe disease in adults below the age of 60, we have been and continue to monitor the data with our colleagues from the US and the UK and previously from Israel when they went through their peak of the fourth wave. And there is no signal that suggests that children are at higher risk of experiencing more disease, more severe disease, and Jeremy will speak to you about this in more detail. Having said that, as you probably have heard over the last few weeks, children between below the age of 12 have become the population with the highest incidence of confirmed SARS-CoV-2 infections, although their rate of hospitalizations thankfully remains very, very low. So in summary, the current wave continues indeed to be driven by the non-vaccinated individuals. And when we look at Ontario, we have done really well when it comes to vaccination rates, because if you look at the eligible population, we are currently sitting at about 86% fully vaccinated individuals. And when you look at the total population, which includes 1 million children below the age of 11, our fully vaccinated rate is sitting at 76%. And I'm saying this on one hand as a very positive sign, but as you can see, there are still a total of almost 2 million individuals in Ontario who are not vaccinated. Which now brings me to the vaccination of children between the ages 5 to 11. And like I said, Michelle will provide you with more in-depth details, but I want to make a couple of general comments. So first of all, the current mRNA vaccines that are now available for children have shown to be incredibly effective and safe. We have had millions of doses given all across the globe, and serious side effects have been extremely, extremely rare. While we, of course, don't have any long-term data at this point, it's really important to emphasize that there is no immunization in the history of medicine that has ever been associated with any long-term side effects. So let's talk a bit about vaccination in 5 to 11-year-old children. As you give this some thought, I really want to acknowledge and recognize that this is a decision that may require some more discussion and consideration from many parents and families, and that is absolutely okay. If you look back at the last 19 months of the pandemic, everything we have been doing, honestly, sometimes on a daily basis, has required us to conduct a risk-benefit analysis. Sometimes consciously, sometimes subconsciously, but think about things like, do I go to the grocery store? At what time do I go to the grocery store? Do I send my children to school? Do I visit elderly family members? We have had to constantly, and to tell you the truth, we continue to assess the risks and benefits of many situations in our life through the lens of this risk-benefit analysis. So many of you will ask yourself, why should I vaccinate my child if SARS-CoV-2 infections continue to be very mild or even asymptomatic in most children? It's a valid question. The answer to this question is going back to this risk-benefit analysis. Yes, the risk for children continues to be very low, but it is not zero. And I would argue, as a pediatrician and as a father, that any child suffering from COVID and requiring hospitalization or experiencing the multi-inflammatory syndrome that Jeremy is going to talk to you about is one too many. Because we now have a tool. We have the vaccine at hand that can prevent disease in children altogether. And this is, to me, the most important reason to consider vaccinating your child or your children. There are some other reasons to consider getting vaccinated. Along with the risk to physical health posed by the SARS-CoV-2 infection, I think you all agree that the pandemic and the public health response to the pandemic have had significant adverse effects to our children in direct and indirect ways. Whether it's disruptions in family routines, school, other educational activities, whether you think about playing, play dates, sports, as well as separations from friends, grandparents, other family members. All of this has affected the mental health and the well-being of children in Canada and honestly all across the globe. So in addition to the COVID-19 pandemic and the response to it, it has also really further exacerbated social inequities among racialized and indigenous communities, refugees, and many other newcomers to Canada's many persons living in low-income settings, and also children with disabilities. So by vaccinating your children, you will help address many of these concerns. And I think this should be part of your consideration and your thought process in your decision-making, although I fully recognize that some of you may disagree with me about this. So let me give you some basic information about the current Pfizer vaccine for the 5 to 11-year-old age group, because it's a little bit different than the vaccine for anybody 12 years and up. So first of all, the dose is different. Each dose contains about a third of the dose that you see in the mRNA vaccine for older people. I also want to talk about the clinical trial because there's a lot of discussions in the media and social media. So I want to give you the real numbers of the clinical trial that has been conducted for the children between 5 and 11-year-old. There were 1,518 children who received the vaccine and about 750 who just received the placebo injection. And these children were followed for at least 2 months. There's an additional cohort of almost 1,600 children who received the vaccine and have been followed for a shorter period of time, but will be continued to follow. And all the interim findings indicated, most importantly, that the vaccine is very efficient and has similar results to the older individuals. And during the time period, no severe side effects were seen. You have seen some local reactions as a sore arm, which you have seen mostly in older children, not so much in the younger children. Some moderate side effects after the second dose, like fatigue and headaches. However, most of these side effects were mild and moderate in severity. To date, until today, we have not seen any cases of myocarditis or pericarditis or any other serious adverse effects, but we will continue to obviously closely monitor this as we are now rolling out vaccination of this age group in many, many countries around the world. It is important, though, to emphasize that the occurrence of myocarditis unrelated to COVID-19 in this age group is significantly less common than in adolescents and young adults. The other important point I want to make is that NACI recommended that the primary series of the 2 doses and the interval between the 2 doses should be at least 8 weeks. And the reason for that is that we have now really a lot of good data, particularly here in Canada, that suggests that the extended interval between the first and second dose of 8 weeks is reducing the risk of myocarditis and pericarditis, and probably also has a better immune response. So let me then close with the following. I think it is really important to take the time to think and discuss vaccinating children between the age of 5 and 11. And yet I do hope that after you have given this the necessary time for consideration, that in the end you will feel comfortable vaccinating your children. Because vaccinating this age group does present us with an incredibly important step toward ending this pandemic. There is, without any doubt, light at the end of the tunnel. And I'm sure you all agree that we want this pandemic to finally end. And vaccinating our children now presents all of us with a really critical opportunity to accomplish this goal. I really would think if there ever has been a need and a time to work together as a team, it's now. And I think we can do this. So thank you, and over to you, Jeremy.
Thanks, Ronnie, for your comments. I'm going to just share my screen because I want to show a couple of slides. All right. There we go. So I'll try and keep my comments quite brief because Michelle's got a great set of slides that's going to address many of your questions about the safety and efficacy of the vaccine for young children. And thanks, Michelle, for loaning me a few of these slides as well. So as parents and pediatricians, I think it is appropriate for us to re-examine the issue of COVID vaccine as it pertains to young children, and the risk-benefit ratio for vaccinating 5 to 11-year-olds is going to be different from the equation in adults. Now, as Ronnie mentioned, with excellent vaccination rates in our adult population in Canada and the more recent emergence of the highly transmissible Delta variant, the demographics of who is testing positive for COVID infection is changing. And as you can see in the top bar there, 21% of the total cases are now in children. If you look on the right-hand side of the slide, you'll see that ICU admissions and deaths are low in children, but they're definitely not zero. The 5 to 11-year-olds in Ontario, if you look at the top blue line in that slide, have now surpassed adults and make up the highest rate of COVID infections. And while we know that children don't tend to get as sick when infected, in small numbers, they certainly can. We know that children transmit the virus, and one assumes that these numbers going into the winter will continue to impact heavily on schools, as well as the social environment affecting children's mental health in the months ahead if we aren't able to provide some additional protection. Now, as pediatricians at SickKids, we do tend to see children with serious and often rare conditions. And frankly, we're not really comfortable if severe outcomes or death only occur in a handful of children. If even one is preventable through an intervention that's shown to be safe and effective, then I think we'd be negligent not to encourage its use. And my impression is that the pediatricians I know are opting to vaccinate their own children at the earliest opportunity. So what exactly are the benefits of vaccination in young children? My opinion is that we should focus specifically on how children benefit from immunization and not view this intervention as part of some master plan of children, again, taking one for the team to protect adults in the community at large. That will likely occur, but it shouldn't be a big factor. So since the pandemic began in March of 2020, so about 20 months ago, we've admitted 287 COVID positive children at SickKids. The volume varies with each wave, but this translates to more than 10 admissions per month. And some of them, especially the older teenagers, have been really sick, including spending time in the intensive care unit on a ventilator. And if you look at reported statistics from the United States, COVID has actually edged into one of the top 10 causes of death in the 5 to 11-year age group, with 143 deaths. Rare, but again, the risk is not zero. This is some more interesting data from the United States, looking, for example, at varicella, that's chickenpox, and the deaths that are prevented by vaccination in a similar age group. If you look at varicella or chickenpox, it's about 16 deaths per year estimated to be prevented versus the COVID vaccination, which would prevent an estimated 66 deaths per year. And you can see quite a few of the other routine vaccinations that we give likely prevent less deaths than the COVID vaccine has the potential to do. Now, in the last 20 months, we've also seen around 250 or about 10 per month children admitted to SickKids with multi-system inflammatory syndrome, or MIS-C, which is a post-viral inflammatory syndrome, usually presents with prolonged fevers, diarrhea, vomiting, rash, other signs of inflammation, approximately a month after being infected with COVID. And about a third of the patients that we've admitted have required some time in our intensive care unit. When you look at some of the statistics from the United States, recent reports describe more than 5,000 children with MIS-C, and half of these were in the elementary school age group, and more than half were admitted to intensive care units. Again, a rare problem, but those affected can become really sick. And then there's the question of longer term problems after COVID infection, or so-called long COVID. The CDC defines this as a wide range of symptoms, physical and mental, that develop either during or after COVID-19 and continue for more than 2 months and cannot be explained by an alternative diagnosis. They can occur even after recovery from a seemingly mild acute COVID infection and can lead to significant morbidity. I have to admit that I think the evidence on this is in its very early stages, and it's really about as clear as mud at the moment. Estimates of prevalence vary widely, and our experience at SickKids so far suggests that it's likely to be quite a lot less common than in adults, where estimates range from 10 to 20% and upward. But in kids, although it's too early to be sure, we're hoping that the estimate will be more like about 2%. At SickKids, at the clinic that's been set up to see children with possible long COVID, the most common symptoms that are being seen include things like isolated loss of sense of smell, sense of taste, post-infectious inflammatory symptoms like asthma or eczema, headaches, dizziness, fatigue, difficulty concentrating, other mental health issues. Thankfully, so far, most children seem to be steadily improving over time. Now, the impact of the social isolation and the disruption to the lives of school-going children on mental health, while sometimes hard to quantify, has been enormous. Research and surveys by our mental health colleagues at SickKids have found that the rates of anxiety and depression in school-age children have escalated dramatically, and I suspect many of you have seen evidence of this. We certainly see this at our hospital on a daily basis. There's been a sharp uptick in the presentation of acute mental health emergencies, a dramatic increase in admissions with severe eating disorders. For example, this week we're running at about 170% of the capacity for our mental health beds at SickKids. Now, children need every layer of protection that we can provide, in order to allow them to return to extracurriculars, sports, and a more normal social life to help to begin reverse some of these mental health impacts. And I'm hoping that I've given you a bit of a local overview on some of the potential benefits of vaccinating children. When it comes to the so-called risk side of the equation, I'm going to defer to Michelle, who's going to answer many of your questions. And spoiler alert, as Ronnie alluded to, the vaccine appears to be highly effective and safe in children 5 to 11, based on trials and the limited use in the United States to date. The only risk that I do want to touch on, and Ronnie's already alluded to this, is that, and we do have some local experience, is the issue of myocarditis and pericarditis post-mRNA vaccination. And for those of you who aren't familiar, myocarditis is inflammation of the heart muscle, pericarditis is inflammation of the lining of the heart, and it can often manifest with symptoms, shortness of breath, some pain in the chest, maybe a feeling of a very fast heart rate in your chest. And myocarditis and pericarditis has been reported certainly in 12 to 18-year-olds after vaccination. Thankfully, there weren't any cases in the 5 to 11-year-old trial, but the numbers are way too low to be definitive. Probably more importantly, we haven't heard of any obvious signal after the first few million doses have been delivered to 5 to 11-year-olds in the United States. But it is true that in Ontario, by the end of October, the reported incidence for myocarditis and pericarditis is about 22 events per million doses. Median age is about 24 years, but certainly has been seen in older adolescents. And the majority are male, almost 78%. And the majority of these events happen in the first week after vaccination. And I think Ronnie alluded to this, and this is from a New England Journal study, but you have to bear in mind that the myocarditis and pericarditis are probably in the region of 10 to 15 times more likely to occur after an acute COVID infection or a misc event than after getting the vaccine itself. And this graph shows that. And our experience at SickKids has been that on the rare occasion that we have seen post-vaccination myocarditis or pericarditis, it actually looks quite different and is much milder than the typical viral myocarditis that we're used to seeing occasionally in adolescents. And again, Ronnie alluded to this, but we anticipate that if there is myocarditis and pericarditis, it will be even less of an issue in the 5 to 11-year-olds, because the experience to date shows that it was actually much less in the 12 to 15-year-olds in the 12 to 18 rollout of vaccination. In addition to that, younger children in general tend to get myocarditis much less frequently. And as Ronnie mentioned, the dose that's going to be given to 5 to 11-year-olds is 1/3 of the adult dose. So again, a lot of reasons to anticipate that this, if anything, will be less of a problem in younger children. So I'm going to hand over to Michelle to talk a little bit about some of the safety and efficacy issues around the vaccine.
Great, thanks so much, Jeremy. And I'm going to move on to talk about the vaccine, how it works, and some of the data that we have in children. So I'm going to start actually with a video. I find that this really helps to sort of explain how the vaccine works. So it's only a minute, bear with me. I hope you can hear.
Coronavirus. Like many viruses, it uses a protein on its surface to attach to and enter our cells. Antibodies that fit onto this protein can block the virus from attaching. Coronavirus mRNA vaccines teach our immune system to make these antibodies. How do mRNA vaccines do that? mRNA is a genetic material that instructs our cells to produce proteins. The mRNA in the vaccine is wrapped in a layer of fat particles that protect it and help it get taken up by specialized cells of the immune system called dendritic cells. Once inside these cells, the mRNA does not enter the cell's nucleus or interact with DNA, but remains in the cytoplasm with other mRNA molecules, waiting to create the enzymes our body needs. When ribosomes read the vaccine mRNA, pieces of the viral surface protein are made. These pieces are then displayed on the surface of the dendritic cell. The dendritic cell travels to a nearby lymph node, where it presents the surface proteins to other cells of the immune system. Some of these cells, called helper T cells, train B cells how to make antibodies that will fit perfectly onto the surface protein of the virus. Other cells stimulated by the protein pieces, called cytotoxic T cells, can kill virus-infected cells. Now, when the coronavirus tries to infect us, our immune system is ready, immediately recognizing, neutralizing, and destroying it before we ever even have a chance to become sick.
All right, so I'm just gonna So this is the video that you just saw by the Vaccine Makers Project. I've included the link there. It's a really great resource for a lot of information on vaccines. So I'd encourage you to have a look at it if you're interested. And so that was a lot of information. So just wanted to summarize some of the key facts that were in that video. So the first is that you will have noticed that the mRNA vaccines don't contain any live virus. So this means that they can't cause COVID-19 infection. As you saw, the vaccine contains instructions to make part of the COVID-19 virus. So that spike protein is what the vaccine makes, and your body learns to recognize that spike protein. So if you're exposed to infection in the future, it will help to prevent or modify infection. But other proteins that are in COVID-19 aren't created. So the whole virus is never actually present, which means you can't pass it on. People that are vaccinated are not going to pass on vaccine strain COVID-19 to other people. The other important fact was that mRNA doesn't enter the center of the cell where the DNA is located. So that center nucleus where we have our DNA, the mRNA doesn't actually go in there. So it's not going to change or alter our genes. In fact, mRNA doesn't stay in our body very long at all. It's broken down quickly within days. And even the spike protein that the mRNA creates only lasts up to a few weeks. So similar to other proteins, they are broken down. The last point, and Ronnie alluded to this, is really that mRNA technology has been well studied. So you hear a lot about the mRNA vaccine being new. It's actually been studied for other vaccines as well as used in some cancer research. So mRNA technology has been there for a while. So now moving on to the pediatric vaccine and what is in the pediatric vaccine. So there's sort of three groups that's in there. There's the mRNA, which we spoke about. That's really what's providing the instructions to build the spike protein that will trigger an immune response when the body sees the spike protein in another if you're exposed to coronavirus. And then you will have maybe noticed in the video as well that the mRNA needs to get to the cell, and it's enclosed in fats or lipids, which help make sure it's stable enough to get to the cell. And then there are some sugar and acid stabilizers. So these are there to help stabilize the vaccine when it's manufactured, frozen, shipped, and stored. So important to note what's not in the vaccine. So there are no magnets or microchips. There are no metals, no preservatives. So it does not require thimerosal or mercury. There are no antibiotics, no medicines or therapeutics. Doesn't use any tissues to create the vaccine. So no animal materials or fetal cells, and no products, no food products, no latex, and no gelatin or pork products used in the vaccine. And this shows you just that they are slightly different formulations, and you will be able to notice that. So the adult formulation there has a purple cap. It's the 30 microgram dose that Ronnie spoke of. And then the pediatric Pfizer formulation has an orange top, and it's a 10 microgram dose, and there are slightly different storage conditions. So just very briefly to give an overview of the timeline, in December 2020, vaccine was first authorized for 16 years and up. This is the Pfizer vaccine. And then in May 2021, it was authorized for those 12 to 15. In October 18th, there was the application that was submitted for 5 to 11 years. And then, as many of you are well aware, on November 19th, the use was authorized by Health Canada for 5 to 11 years old. And just to compare to the US, so US, the timeline was slightly sooner than us. So October 29th, FDA authorized the use for 5 to 11-year-olds. And then November 2nd is when the CDC formally recommended vaccine for all children 5 to 11. And similar to CDC, NACI, which is our National Advisory Committee on Immunization, came out with a statement the same day as Health Canada around the use of Pfizer vaccine in children 5 to 11 years, recommending that it can be offered for those who don't have contraindication to the vaccine, with the dosing interval of 8 weeks between the first and second dose. And Ronnie mentioned that longer interval is really based on data that we have from the adult and adolescent vaccination rollout, suggesting that it may help improve the immune response, as well as the longer interval being associated with less adverse events. So now moving on to the trial. This is the trial that these recommendations and these reviews are based on. So this is the evaluation of the Pfizer vaccine in children 5 to 11. So phase 1, sorry, I'm just cognizant of time here. I'm realizing I'm probably running out of time here. So phase 1 was the initial stage where they were vaccinating 48 participants to determine the preferred dose of the vaccine. And this is where they found that the 10 microgram elicited a similar immune response to the 30, but had less side effects. So the 10 microgram was chosen to go ahead in the phase 2-3 part of the trial, where they randomized children 5 to 11 years of age to either vaccine. So there are about 1,500 in the vaccine group and 750 in the placebo group. And again, the purpose of the study was to assess the safety, immune response, and efficacy. The follow-up was 2.3 months, but there will be ongoing follow-up for 2 years. And then participants were tested if they had COVID-19, if they had symptoms, they were tested for COVID-19. And so the data was that with 2 doses, it was 90.7% effective in protecting against symptomatic confirmed COVID-19. So really great results. And this is just the overall vaccine efficacy. This is from the Ontario Science Table dashboard, which is a great dashboard to look at for those who want to get data. And this looks at the current COVID risk in Ontario by vaccination status. So you can see here COVID-19 cases, patients in hospital, and patients in the ICU, and how that varies by fully vaccinated or unvaccinated. So you can see significantly more people are unvaccinated in all 3 of these categories. Okay, so now going on to the risks. Jeremy spoke about myocarditis, pericarditis, so I won't go through that. I'm going to talk about what they found in the trial and some of the other concerns that you've raised or questions that you've raised already. So these are the local events that participants noted in the trial. So you can see on the left there, it's the percentage of participants and dose 1 and dose 2 there. So redness, swelling, pain at the injection sites were the local side effects that were noted. And you will see that pain at the injection site is by far the most common after both dose 1 and dose 2 for participants. And then this is looking at systemic events and the use of the vaccine. So again, at the top, you can see it's after the first dose, and the bottom graph is after the second dose. And then along the bottom there, you can see the different side effects that were reported, and then the percentage of participants who were reporting those side effects. So fatigue and headache were by far the most common after both dose 1 and dose 2. And then you can see there that fever occurred in 7% of people receiving the Pfizer vaccine. So sorry, just to orient people, the BNT 162b2, that's the Pfizer vaccine, and then the placebo are the people that did not get the vaccine. And so to compare to the data from the 16 to 25-year-olds, so this 7% compares to about 17% in the older age range. So really a very similar side effect profile to what we see for adults and adolescents, but likely less severe in terms of frequency. So as has already been mentioned, there were no serious or severe adverse events that were related to the vaccine, no episodes of anaphylaxis, and no myocarditis or pericarditis. And to summarize, the most common side effects were really those that occurred locally, like injection site pain, and then systemically were fatigue and headache. So one of the questions that I think a number of you have asked is, with such a low number of people in the trial, how can we be confident in the safety data? And you're right that the published trial really did have a small number, 1,517 children that received the vaccine. So you're not going to pick up the rarer events with those numbers. But what's fortunate is we really have a lot of real world experience. So we have millions of Pfizer vaccine doses that have been given to those 12 and older, over 200 million in the US, over 400 million Pfizer doses in the EU. And then more recently, we have more than 2.5 million children less than 12 years of age in the United States that have received their first COVID-19 vaccine. So they started vaccinating early in November, and they're using a 21-day interval between the first and second dose. So really, by the time we're giving our second doses at the 8-week interval, we will have accumulated a lot of even more real-world experience with the vaccine in pediatrics. And we know that there's, in both Canada and the US and in other nations that are starting to vaccinate this age group, there is robust ongoing surveillance. Okay, so just to address some of the frequently asked questions that have already come up. So this was a common one: can the vaccine impact fertility? So this came from early claims that the spike protein, which the vaccine, the antibodies against the spike protein, which the vaccine results in these antibodies, will also target the placenta of pregnant mothers. And so but when you look at the data, they're actually very different proteins. So there's no similarity in amino acid sequences between the spike protein and this placental protein. And when you take convalescent, so if you take serum from patients who've had COVID-19, it doesn't react with this placenta protein. So really, theoretically, there isn't a strong basis for this claim. And we also have data from those who have had infection and vaccination, and real world data evidence does not support an association with increased risk of miscarriage. So overall, there's no evidence to support that the vaccine can impact female fertility. And there's also no evidence to suggest that the vaccine will impact male fertility. They've done studies looking at sperm parameters before and after vaccination, and no differences have been noted. Next is whether it can cause menstrual irregularities. So there have been reports about heavy menstrual bleeding as well as intermenstrual bleeding, but overall it's felt to be relatively uncommon. Fortunately, when it does occur, it appears to be transient, and it's also seen with both acute and long COVID. One of the challenges with monitoring this is it's difficult to link menstrual changes with vaccination, given the multifocal reasons for menstrual changes. But to date, there's no confirmed link, but it's something that there's ongoing surveillance. I won't spend a lot of time on this. Ronnie spoke to this already. Questions about longer term side effects and things we may not know about with the vaccines. So vaccine side effects, as Ronnie said, occur very early, and the vaccines are eliminated quickly. So it's not like a medication that builds up in your system. It's something that's eliminated. So we don't anticipate longer term side effects, and there's no impact on our genes. Some practical questions that have come through about the flu vaccine at the same time as the COVID-19 vaccine. So right now in both United States and Canada, for those 12 and older, it has been, it's recommended that you can or the guidance is that you can get both at the same time, but in different locations. But with those 5 to 11, NACI is recommending a more cautious approach. So they want the 2 vaccines to be 2 weeks between them, so that if there is a safety concern, it will be clearer which vaccine may have caused the problem. So for those 5 to 11, they are recommending a 2-week interval between the COVID-19 vaccine and influenza vaccine. This is just about if a child has had previous COVID infection, should they get vaccinated, and similar to the recommendation for adolescents and adults, 2 doses can still be offered to children who have had a previous history of infection, but to receive the vaccination, they should no longer be considered infectious. So they should have been cleared from their isolation by public health, and symptoms of acute illness should have completely resolved. And if children had a previous history of MIS-C, again, they can be vaccinated, but the vaccine should be postponed until there's clinical recovery or there have been more than 90 days since the diagnosis, whichever is longer. Last 2 FAQs before I'm done. So this next one is, should the vaccine dose be based on weight? A couple of questions have come through. If your child is smaller, should they get the lower dose? So vaccines are different from medications in that when they're given, they're not distributed through the body. And so weight-based dosing isn't needed. The vaccine is really processed locally. Once it goes into the area, it's not something that's distributed. So dosing is based on the maturity of the immune system, which depends on age, not weight. And then finally, should your 11-year-old wait to get the higher dose of the vaccine? And the recommendation for this is really that they should get the first vaccine available to them. So if they're 11 now, they should get the vaccine now and not necessarily wait until next year to get the higher dose. And so the approved vaccine for 11-year-olds, so when you look at this breakdown by age in terms of the immune response, you'll see the 9 to 11-year-olds, when you look at their titers, which are sort of the antibody levels post-vaccination, you can see that they're relatively consistent across all age groups. So if your 11-year-old gets the 10 microgram, 5 to 11 dose, it would be anticipated that they should get a good immune response with the potential of even having less side effects associated with the lower dose vaccine. So I'm going to end there and just encourage you all to ask questions. These are some great resources. Kids Health First, University of Waterloo has some great infographics, a number of which we've used in this presentation, and also about kids' health. Thank you.
Thanks so much to all the panelists. I've been reading the questions appearing on the chat in the Q&A. Many of them were submitted in advance too, and you really did a wonderful job speaking to a lot of the questions. I would like to acknowledge that some of them were really heavily represented, so I think it's worth at least knowing that this is on parents' minds. There were many questions about the 11-year-olds. Should we be waiting until January and then they can access the adult dose? Is there any benefit to doing that? If I understood what you were saying in response to that, Michelle, it was actually that they would get the immune response that they need, whether they're 11 or whether they're 5, and there's even less chance of side effects, so that it sounds like a benefit all the way through. A question that also came from that same cohort of parents wondering about their 11-year-olds is when the 8 weeks are up, which gets us into 2022, will they be receiving the adult dose as the second for their second dose, or will children still get the pediatric dose?
That's a good question, actually. And I was going to have a look at the NACI statement to see what they recommended. I don't know, Jeremy or Ronnie, if you know. I think either would. Oh, go ahead.
The NACI recommendation is actually that if within the 8-week interval your child turns 11 or 12, then you can get the higher dose. That's the NACI recommendation right now.
That's 12.
Thank you. There was certainly a lot of questions about 11-year-olds or 10-year-olds that are as big as 12-year-olds. There were also some comments from the parents of kids on the other end, the 5-year-olds. They said, what if my child is a small 5-year-old? Is there reason to wait? Is the general agreement that there is no reason for someone who is turning 5 this year to wait if they're small, or if there's any other indications?
Based on what we've seen from the recommendations, as Michelle mentioned, it's really related to the maturity of the immune system and not the size or weight of the child. So I think the recommendation is, regardless of the size of your 5-year-old, they would be appropriate for the 10 microgram dose.
And where do things stand on the 4-year-olds and younger?
I think as far as we know, Michelle, you might have a more updated, but certainly according to Anthony Fauci, the results of the trial should be coming through in the next month or two. And I think their expectation is, going through all the regulatory agencies and getting the approval that sometime in the new year, probably in the spring, is when we might see vaccination for the under 5 age group.
Are there any health conditions, again, questions from parents, thinking about children with various health conditions, are there any health conditions or vulnerabilities that suggest that some children should not be vaccinated?
At the moment, there are no health conditions that where anybody would recommend not to immunize a child. I think what we do know is that individuals with an immunocompromised situation due to various reasons probably have earlier waning of the immunity and need a third shot or booster shot earlier. But there's no contraindication with any medical condition not to get vaccinated.
And is it in the anticipated future that there will be boosters for children as well?
I think that's a difficult, Michelle, Jeremy, I don't know. I think it's difficult to answer this question because the immune system of children really responds differently than of adults. And I mean that in a positive way. So I don't think it would be unreasonable to assume that a 2-dose vaccine regimen for children, particularly the younger children, might be sufficient, particularly now if we do the 8-week interval. I think this is a little bit something that we have to observe over time.
There were quite a few comments in the chat about asking why NACI has an 8-week interval versus the CDC's 3-week. People seem to know that the trials were used a 3-week interval, and maybe that's why the CDC followed that recommendation. Could you say more about why NACI chose to prolong the duration between the 2 doses, and why 8 weeks and not, I don't know, 9 or 10?
So happy to start. I think that the main reasons are really from the data that we have from the adolescent and adult vaccination, where prolonging the interval has resulted in, or there's evidence to suggest that there's a better immune response with prolonging that. And actually that's similar to other vaccines that we have where the dosing interval. So there's a theoretical basis as well that a longer interval may make sense. And then we have some experience with the adult and adolescent vaccine rollout and also with the potential for reducing side effects. So I think those are the 2 main reasons why they've taken the more precautionary approach here.
Thanks for that answer. Many of the questions seems to be there seems to be a common struggle for parents who are still unsure about vaccinating their children. It seems that many parents felt confident about getting themselves vaccinated, and older people in their life, maybe grandparents too, but it's still, the concern is still about whether the risk benefit is properly weighted, given that the number of severe cases of COVID among children is so much lower. Is the sort of unknowns and potential side effects of vaccination, is that a good reason not to vaccinate children, given that COVID is not often severe?
I mean, I'm happy to take a shot at that. I mean, it doesn't surprise me that parents struggle a bit more with this decision, because I think the risk-benefit ratio is a little different. I think the risks to the elderly in particular, and even adults in general, is the risks are definitely higher. So I think it's not surprising to me that parents are battling a little bit more. But I think one of the things we tried to outline in the comments were, on the one hand, there are quite a lot of benefits to children. And from what we've seen from the evidence and even the real world experience, it really does appear to be a very effective and safe vaccine. And certainly in the healthcare field, particularly in pediatrics, vaccination is probably perhaps the single biggest game changer that we've seen in so many diseases, that perhaps it's a little easier for us to see the value. But it doesn't surprise me that parents are struggling, and I think it's reasonable for individuals to look at what is being said and what's being written. I would prefer them to look at sources that are based on science and evidence, rather than Facebook and Twitter. But I think it's a very reasonable approach for a parent to take, and maybe for some parents it'll take a little while longer to feel comfortable. But I think certainly as a group, and I mentioned that when I look at my colleagues who are pediatricians, my kids are a little older, but when I look at my colleagues who have kids in the 5 to 11-year age group, they were on the phone getting the appointments at 8 o'clock in the morning the other day. So that says something to me as well.
And do you have any, oh, sorry, Michelle.
No, I was just going to say, so for me, my family recently went through this decision-making process for my kids who are in this age group. And ultimately, when we reviewed the data, and especially with the experience in the US with over 2.5 million doses being given, it really ended up being quite an easy decision. And I was really excited to book the appointments when the opportunity came. So I would encourage everyone to reach out to their trusted healthcare workers or good information sources to get the information that you need to make the decision for your family.
Do you have any messages for the parents who just want to wait and see a little bit longer?
So maybe I try to take this one. I try to outline this in my opening remarks. There's a lot of discussion about the so-called no-brainer decision to immunize adults, and I fully believe in this. Many of you know we have mandated vaccines for our staff members at the Hospital for Sick Children, given the vulnerability of the children we care for. I do think it's a different situation for the 5 to 11-year-old children, and I'm very much against stigmatizations of children, parents or caregivers of children in this age range. If you need more time, while I hope we did a somewhat decent job to convince the ones who are still hesitant about it, you need to take the time, you need to do your own personal individual risk benefit analysis. And if in the end you decide to wait, I'm not one of the pediatricians who will stigmatize against you, and I think nobody should.
Thank you. Do any other of the panelists want to say something to parents who are still unsure or want to wait a little bit longer, wait and see?
Can disagree with me.
Thank you to the panelists. I think that actually captures the many questions that I had. Some people wanted to get into discussion about school mandates, but I think that still waits. We'll sort of have to wait and see on that. There's more to be discussed on that. So I'm going to turn this over to Nancy.
Thank you, Maya. Oh, I have a bit of a cold. Excuse me. I don't have COVID. I had my PCR test to check. Maya, you've done just a beautiful job of synthesizing the questions that were in the chat. There are many of them. And Ronnie and Jeremy and Michelle, I want to thank you so much for the way you addressed so many of the questions in your presentation. We will be posting this recording on our website, which is www.mabin.com. We have a COVID page. And so if anybody would like to share this event with friends or family, it will be available there. And I just want to thank everybody again for joining us tonight. This is an exciting time. These are difficult decisions. And like our panelists, I hope in the end, everyone will decide to vaccinate, but good for you for asking questions and thinking it through. And we look forward to seeing the end of this pandemic. Every time we have a panel, we say, we hope this is the last one. We hope this is the last one. But we want to thank all of our panelists for spending this time with us tonight. And good night, everybody.
Thank you.
There was a quick question in the chat to ask where the video would be posted. So I'm just chiming in to let everyone know it will be on the COVID page of our website. It's on the screen there in front of you, www.mabin.com.